Hey, thanks, Paul. Thanks for having me today. Appreciate your stamina. I'm fully aware that I'm standing between you and the freedom. Let me just put it on the full screen. I am happy to drop one of them if time is an issue. Let's start with the PFO, as I have called it, how to bring out the PFO. And with that, I'd like to start a bit of embryology that essentially tells us how this foramen ovalis is formed. Early in development, as you would know, there is a single common atrial chamber, the primitive atrium, and then you have the septum primum, that is a relatively thin crescent-shaped type of structure coming down, and at that point you will have the ostium primum, which allows for the shunt of the blood from the left side to the right side within the for the fetal circulation, and as it approaches the endocardial cushions, another orifice starts to pop up in the upper part of that septum primum, and then the septum primum is joined to the endocardial cushion. Now, the second septum secundum, which is essentially a muscular rim, comes to the right side of the septum primum, and after birth, with the first breath essentially, an increase in left atrial pressure, that flap type structure will be sealed. But in 20 to 40% of population, as you would know, this won't be sealed, and therefore there would be a channel type connection between the left and right atrium, or so-called foramen ovale. So and with that, I'd like to show you these cadaveric pictures that essentially shows the anatomy from the right atrial side and the left atrial side. In the right atrial side, you can see some key elements around the foramen ovalis, which is important, including the SVC, IVC, eustachian region valve, coronary sinus, and then you have the tricuspid valve down there. And interestingly, in the left side of the structure, because the orifice comes out of a tunnel, as you can see, it's slightly above the actual fossa and very close to the aorta, which has a procedural implication as the disc will sit against the aorta. How to diagnose it? The first step, and perhaps the most important one, is the bubble study by transthoracic echo with excellent specificity and also very good sensitivity. And you can see that the sensitivity is a bit wide, and that's all dependent on how strong and effective your Valsalva maneuver during that transthoracic echo is. TOE limited in terms of the actual contrast, unless you see the colored Doppler shunt. But if you want to do the bubble contrast study by TOE, it's a good practice to do it from the leg because of the direction of the inferior vena cava that is essentially towards the fossa ovalis, and pressing on the abdomen will replicate a type of Valsalva maneuver. But you often get the diagnosis right by bubble study, and TOE is more for planning the actual procedure. So when it comes to the 2D echocardiography, what you need is a list of things that I have summarized in this slide. We talk about the terminology, which is the tunnel, the width, and the height or separation. It's important to look at the septum in terms of whether it's aneurysmal or not, septum secundum in terms of its thickness, pulmonary vein drainage, and of course any other important finding around this structure. So with the 2D echo, what you need is a good sweep of the fossa ovalis. So, and the recommended way of doing this is to start from the upper esophagus to the mid esophagus to the lower esophagus, and with each one you sweep from 0 degree to 120 degree, and therefore you would be able to identify the foramen ovale if it's present. There are two views that are essentially called specialist views, and those are the around 40 to 50 degrees when you cut through the fossa ovalis and also the foramen ovale, and 100 to 120 degree, which gives you the bicaval view. And with presence of color, you will be able to identify the PFO, or if it's not, and the diagnosis has been made based on the TTE, you often see the flap and the entrance and the exit of that. A bit more angle, about 120, would expose the right upper pulmonary vein, which is a good practice always, where you can also see some of the congenital defects such as sinus venosus. With that in mind, and also one trick, if you want to look at the bottom part of the essentially fossa ovalis, it's a good practice to go to the stomach, come back and identify the IVC in your transgastric view. And as you come out of the stomach, then you will see the bottom part of the septum and the IVC, and that's where you also could identify some of the inferior ASTs. So these are the type of abnormalities you may face when you are investigating PFOs, a very aneurysmal septum. The definition usually is if it's bulging beyond 10 millimeter. You can see a very thick septum here in the left side, which poses some challenges in terms of closing these devices, and you might see a small AST just next to the PFO, which is not a big deal. But if you see several PFOs or fenestrating holes across the septum, that will pose a challenge. Sometimes the PFO is so-called stretched, and the color Doppler comes as if there's AST, but that's essentially where you have a really big PFO. This is the case from like 5 or 6 years ago, and as you can see, the images are a bit not usual images. This was done on a nasal probe because the patient had issues with their esophagus. Right, so if you ask me how to bring out the PFO in cath lab, I'm a big fan of 3D analysis of these structures, and I'm going to actually demonstrate how I would do it and how the 3D could help you to understand the fossa and essentially the foramen ovale. So how to acquire the image? It starts often with the bicaval view. You use your 3D zoom, include the narrowest area of interest that you want and some anatomical markers such as aortic valve. You need to toggle between fundamental and harmonic imaging, a bit of play with the brightness, compression of the 3D image, and almost always you can get it from 3D. This image would pop up when you do the 3D zoom, and these are obviously Philips images, but that's how it will look like when you press on the 3D zoom and you've done your biplane imaging and you have included the area of the interest. Then you need to move it and rotate it away from you. That will give you a view from the right side of the heart. And if you rotate this 90-degree to the left side, then you will expose a view that is similar to fluoroscopy view, how the interventionist will see the structures on fluoro. This is almost a RAO view for the interventionist. This is a recorded view of how to do it. So that was the biplane view away from you, and then 90-degree to the left will give you the view with SVC on the top, fossa, aortic valve, mitral valve, and IVC down there. So I want to spend some time on the fossa ovalis itself, because you had a talk on transcatheter mitral valve edge-to-edge repair, and you talked about the septal puncture, and I want to use 3D to go through the anatomy of the septum. So what you are having here is a multiplanar reconstruction of the same 3D data set that I just showed how to acquire. And this is from the right side of the heart, as we discussed. By adjusting your planes, in this case, the green and the red, you will reproduce your 2D imaging from 3D imaging. So on the top left, you have the bicaval view by placing the green line across the area of interest, and on the top right you will have the short axis view represented by the red line here. And you can see by moving the red line you can toggle between the mitral valve, so you can see the distance from the mitral valve, and also coming back to the aortic, which is more relevant to the PFO. More importantly, these views would be similar to the LAO and RAO for the fluoroscopy, so the interventionists will have a clue how you are looking at. Now, if I go to the left side of this, let me just try to, so these are the fluoroscopy view. Now, if I rotate it and look at this from the left side, from the left atrium, and if you focus on the green and the red line again, you could see that the red line, which is the short axis view on the top right, tells us how far from the aorta and mitral valve we are, or the distance from the mitral valve. But the green line, which is the SVC, and anatomically called superior and inferior, it doesn't really translate into the superior, inferior to the mitral valve and aortic valve. In fact, that terminology of superior and inferior is anatomical alongside the body. So what this means is when you are aiming for transeptal puncture, if you puncture, for example, here, let me just go to the end of the video again. If you puncture there, which is the top of the fossa, if you puncture in the mid and in the bottom part, there are different implications. So with all three punctures, you have the same distance from the aortic valve and mitral valve. So if you want to do, for example, a transcatheter edge-to-edge repair, you want to go as posterior as possible, as you probably have heard. But in terms of the IVC SVC puncture, you can see a puncture on the top part or close to the SVC will give you a trajectory towards the medial side of the valve. The middle part will give you the best trajectory towards the coaxial to the valve, if you like it, and the inferior puncture will drive you towards the lateral aspect of the structure, which is the left atrial appendage. So in summary, where you choose to puncture from superior to mid to inferior, if the fossa allows, gives you the trajectory, and a posterior puncture gives you the distance from the mitral valve. So almost always with any procedure, you puncture posterior because you need enough area, enough distance from the mitral valve or LA appendage, and then depending what you want to do, you puncture superior, mid, or inferior. For transcatheter edge-to-edge repair, you puncture at the mid part. For LA appendage occlusion, you puncture the inferior part. And if you have a paravalvular occlusion, you want to medial side, for example, sometimes a superior puncture would help. So the bottom line in summary is that SVC, IVC determines your trajectory, AV, anterior, posterior, then gives you the distance from the mitral valve. So how we can apply that to the PFO? So we talked about some terminology about the width, about the length, and the separation. And here we are looking again from the right atrial side in a case that clearly there's a PFO with a flap that you can see. And by moving the plane across the tunnel, so the red is the short axis. You can see by moving the red from one side to the other side, you open up the separation of the leaflets. So this is called tunnel, and that is called width. And that is called the separation or height. So the tunnel goes that direction. And if I show this to you from the left side, you can see that the exit is at the top part here. That's the fossa. And therefore, this is the width as I'm moving. And we are interested in the right atrial side of that width because the device will sit in this side. And if you occlude that part, there won't be any shunt. Therefore, the width itself is an element. The tunnel itself is an element. And the separation is more about the risk of a stroke rather than procedural implication. And the question will come, which one to use to do sizing if there is such a thing for the PFO, and we'll talk about that a bit. So you can use real-time MPR as nicely demonstrated by Andy in the tricuspid imaging. You can do exactly the same for any structure essentially. And here you can see in the left side image that the real-time MPR, not the offline analysis, was used to reveal the anatomy of the PFO. And biplane itself, which is a feature of 3D also, is very helpful if the 3D is not, a 3D zoom is not easy to do. So coming to the PFO closure, a bit of history. It goes back to 1970s actually, but it was only in 1992 when more dedicated devices came through. And these are the devices that at the moment we have, the Occlutech, the Gore, and the Plaza. They are essentially non-central devices, meaning that they don't have a fixed waist, and therefore they will be a bit more flexible because it's a tunnel, not a hole, as opposed to ASD. And you have the Amplatzer cribiform device, which has a very narrow waist and is used for fenestrated ASD, and sometimes in very aneurysmal septums that also is being used. These are the sizes that are available that you can see from different manufacturers, and I'm going to be a bit more brisk with that. And when it comes to the device sizing, there is no standardized way of doing that. In fact, some operators, experienced operators, they do all of that on fluoro. So they get a TTE and a TOE, but then the procedure itself will be done on fluoro, and they have very simple rules as illustrated on this slide. So essentially, Bernard Mayer in Switzerland put a balloon across the PFO, and if it's stretched less than 12 millimeters and it's not an aneurysmal septum, and a standard PFO device, which is 18 millimeter in the left side and 25 millimeter in the right side. And then if it's aneurysmal or aneurysmal and thick septum, goes to the upsize it to 35-25, a very simplistic way of doing this. But there are ways of doing this based on the echo. So you can use the tunnel as we discussed. You can use the width. You can use the so-called balloon sizing by fluoro, and then you can use the balloon sizing by 3D echo, which I'm not aware of many centers, but we've been doing that historically for several years. And essentially, you also want to know the shortest dimension of the left atrium, because the left atrial disc sits against the aorta, and you want to make sure that it is not crowded and won't cause any erosion. So intraprocedural TOE helps with crossing PFO. It really goes through if it's a big one, but if it's small, sometimes they need a bit of guidance and it will help. And then you will get a short axis view to monitor the delivery of the sheath and exposing the device. And essentially, you want to see the device is coming back against the septum, because you don't want to deploy both discs in the right atrial side, obviously. And then the right atrial disc comes, and then you check for shunt, and the procedure is done. So this is how we do it with balloon sizing for with the 3D echo. So a balloon is very carefully inflated, and essentially by multiplanar reconstruction, you go at the waist of the balloon, and you will see the two dimension, or in other words, at that view, which is taken from the short axis view, you are essentially stretching the width of the PFO tunnel, and then you are going to add a few millimeters to that to make sure that it's covered. So there's no real guidance of how much to add or which size goes to which device. It's a bit of common sense and intuitive decision. If you have a 21 millimeter stretch on the PFO, then obviously you upsize to a 25 millimeter device that would be suitable. Some advocate for only use of the width measurements that I already showed to you from 3D echo and add a few millimeters to that, and some use the tunnel. So there's no real standardized guidelines in that department to follow. And this is a case just to demonstrate how all this is being done. So the standard views are the short axis view, the bicaval view, the color doublet that really doesn't show much in this in terms of the shunting, the short axis view and the shortest dimension of the left atrium, which is about 28 millimeter in this case. And here is the wire that goes through the PFO. You can use both 2D and 3D for that purpose to ensure that the wire is through. And then this is our 3D balloon sizing, another case that shows 17 by 18 millimeters. So adding a few millimeters, again, goes to the 25-30 or 25-25. And the right side image shows the fluoro, and then you can measure the weights here for sizing when it's based on the fluoro. So these are the sizes from the Amplatzer device. And with this case being 17-18, you either need to go to 30-30 or 30-25, or you can use Amplatzer device, which has 25-25 millimeters. As I mentioned, you use the short axis to monitor the left atrial disc to come and sit against the septum. And then as demonstrated in the right side image, you also want to watch how the right atrial disc comes and it presses the septum, and then there is a bit of angulation always with the Amplatzer device, and that's because of the delivery system. And when you release the delivery system, it will sit a lot more nicely and more aligned with the septum. You can use 3D for those purposes, and then obviously you put your colored doppler to make sure there's no residual shunt. You can reduce the scale to pick up any low velocity jet, and when you are happy, the device is released, which, as I mentioned, when it's released, it sits a lot nicer from what you have seen. And all these patients come back for a follow-up, minimum 6 months or 12 months, another bubble study to ensure that there is no residual leak. And with that, our first topic is done. Paul, do you want me to continue, or in the interest of time, you want to call it off? I don't mind.
So you're the last speaker of the day, so I'm happy if you want to go on.
Oh, yeah, absolutely. No, yeah.
All I'll say to the people in the audience is if you are kind of disappearing during the talk, then please have a look in the meeting chat, because the feedback code for the entire meeting is there for people to fill in. Mehdi,
All right.
in terms of your
Sure.
presentation, if you just hit the slideshow button, it might give us the full screen.
Oh, I have
The
been
slides
giving you
the slides have been
sorry.
working fine, but they've just I didn't want to interrupt your flow. So we have seen everything, but it's just not been maximized to
Oh,
the screen.
it was maximized on mine, but somehow, let me just stop sharing and then bring it again. Okay, let me just do it again. Is that better now?
Yep, that looks better.
Okay, you should have interrupted me. Okay, walking into the realm of left atrial appendage, which has essentially extreme variability. Oh, okay. And it's been sort of like described as our fingertip, is the most perhaps lateral structure of the heart. It, as I mentioned, has extreme variability in shape, but essentially it has a very distinct orifice that ends into a neck, and then to the lobes, which could be one or two or several. And strictly speaking, when we talk about a lobe, it must be a visible outpouching from the lobe. And some of the anatomists say that it has to accept a 2 mm probe internally, otherwise it won't be a lobe and could be essentially a little bulge. And these lobes are important, and we will discuss them in a second. In terms of how it lies, it often has an anterior and superior trajectory towards the right ventricular outflow tract and aorta, as you can see here. But there are cases that is completely reversed to the other, and that makes assessment of the left atrial appendage very difficult. The pectinate muscles are important. They could be a problem, and as you can see in the next slide, it also has a very paper thin wall, and therefore the risk of rupture is real with left atrial appendage occlusion. There are some really key elements surrounding the left atrial appendage, and knowing how thin it is, then there is a real risk of injury to the coronary arteries, particularly to the left circumflex artery, and also the pulmonary vein, which is like adjacent to that, and some other structures which are there but rarely affected by the device in terms of complications. These are some images from left atrial appendage the image E, for example, shows how pectinate muscles are extended into the left atrium. And sometimes you have accessory lobe next to the main ostium, which makes it very difficult to close. And the ostium itself could be extremely elliptical, as demonstrated on the cadaveric images and also on the 3D echo. Morphology, I'm pretty sure you have heard about them, although the reproducibility of these morphologies are not really high, especially with the 3D echo. CT is a lot more helpful, but that's how it's been described. But more important than the morphology itself, is important to understand where is the ostium, is there an angle, and how the lobe is coming off from the ostium. And from a procedural point of view, as you would imagine, the chicken wing is the most challenging one. And when it comes to the chance of stroke, the shallow ones, the cauliflower, which is usually very shallow, carries a bit more higher risk in terms of the stroke itself. So, imaging left atrial appendage, these are the summary of the things that you need to assess. You want to know about morphology, you want to know about the ostium, and the landing zone. The device won't sit at the ostium, it will sit at the neck or the so-called landing zone, which we'll talk about that in a couple of minutes. We want to know if the ostium and the landing zone are very elliptical or not elliptical, because circularization of these areas may not be feasible, and therefore there might be a risk of leak. Angulation, as I spoke about, for example, chicken wing, is a challenge. If there is no adequate depth to put the device in, then you wouldn't be able to do the procedure. Pectinate muscles could pose a problem, and essentially accessory lobes and where the coronary arteries are coming, how close they are to the LA appendage, and also the pulmonary veins, those all needs to be assessed either by 3D echo or sometimes CT. So the devices that are at the moment more commonly used is the Watchman device. The lower one is the more recent one. It's called Watchman Flex, which has a closed end, and the top one is the iteration 1, which has an open end, similar to a strawberry. Essentially, you want to shove this one into the appendage. This is the amulet device, which has a disc that is meant to sit on the ostium, and a lobe or a tire that is meant to occlude the neck or the landing zone. These are the manufacturer recommended measurements. So you need to measure the ostium, identify the left circumflex artery, draw a line about 10 to 20 millimeters below the ridge for Watchman. And with the amulet, because the device is coaxial to the neck, the lobe or the tire, you come down about 10 millimeter below the top of the ridge and measure that area as your landing zone from 2D echo. Where in cardiac cycle, obviously, when the left atrial appendage is a larger size, and you almost always need a bit of hydration to increase the LA pressures below beyond 12 if it's done intra-procedurally. So these are the routine standard measurements you want to do at 0 degree, 45, 90, and 136. But you all would appreciate that it's not easy, for example, to sometimes get the 136. And more importantly, when you're looking at this view, you would see that the short axis is not necessarily the short axis, the green one, is not necessarily cutting. Sorry, the red axis, which is the long axis, is not necessarily cutting through the largest dimension. That is the inherent limitation of 2D echo, because you don't know where you are bisecting the structure. And as such, again, similar to the other procedures, you need a 3D imaging modality. And here I have again reproduce the 2D imaging from 3D just to show you how that green line in this case is cutting through here rather than here, and that the red line is cutting through there, which is not necessarily representing the longest dimension of the structure, and they may underestimate the size and therefore the risk of smaller devices and embolization. So how to do it from 3D echo? This all can be done by CT, but the talk is on the 3D echo. So essentially the same concept again, 3D zoom, a bit of anatomical areas around it. The blue line is parked around the left circumflex artery, which is here. You put the red, and then you will create the short axis view and the long axis view. By rotating the red, you would appreciate the inside the appendage, the pectinate muscles, which are prominent. And then as already alluded to, there are measurements that has to be done in certain distance from the top of the ridge, and these are the most accurate way of doing those measurements as by 3D, and this is how you do it. You can do the perimeter area, but often the 2D measurements are taken for sizing, not the area or perimeters themselves. If you're a Philips user or a GE user, there is newer modalities such as glass view helps to understand the morphology, because with the 3D echo itself, it's really difficult to understand morphology. With the glass view, when you increase the transparency, in this case, you can see there's one lobe coming, and this is the windsock that you are seeing in this view. In terms of the actual procedure, in the beginning, when we start, want to show there is no thrombus in the left atrial appendage, obviously. As I mentioned, hydration is important, and keeping the LA pressure beyond 10-12 will often give you the largest size of the left atrial appendage. Intraprocedural TOE, the baseline echo with the left atrial appendage is really important. These procedures sometimes may go wrong. Pericardial effusion can happen in maybe 1 to 2% of the cases, and therefore if you have a baseline imaging, especially from transgastric view, ensuring that there is no pre-procedural fluid is really important. We're going to talk about transeptal puncture, positioning, post-deployment, and the final check. So we talked about the transeptal puncture. You would remember for the LA appendage, we want to go lateral. Therefore, you want to puncture a bit inferior. So that's the SVC, and you see the puncture is happening away from the SVC, closer to the IVC, and then you go as posterior as you can, and that will give you the trajectory that helps to approach the LA appendage in a more coaxial view. There are some innovation in the field. CT can be used with some very interesting finite element analysis model to figure out exactly where you need to puncture, which is a bit beyond the spectrum of this talk. So this is a case, and this is the standard imaging that you need to do for the appendage: 0 degree, 45, 90, 130. You do your 2D measurements on this because this is what the manufacturer recommends, but you are also aware that you might be undersizing the appendage if you're not cutting through the maximum dimension of the appendage, and therefore 3D needs to be done. This is 3D zoom. I always include a bit of aorta and mitral valve because that helps me to reorient myself. So that's the pulmonary vein up there, appendage, that's the aorta and the mitral valve. And then you do the multiplanary reconstruction. You can do it real time. You can do it offline analysis, and the same concept that we talked about. So essentially creating your 2D views from 3D image with the knowledge that you're bisecting exactly where you want to go, and that helps to get more accurate measurements in terms of the sizing. In this case, I just go to the end of this to show you some of the measurements that has been done. And this is like the depth and everything, and I think is about 17 by 18 in terms of the sizing. I think it's a bit earlier when I demonstrate the measurements. Yeah, so that's the D21, which is 22, and then 17 by 22, which is bigger than what you have seen from 2D echo, again highlighting the importance of 3D imaging modality. So the sizing comes from the manufacturer. This is the amulet device, and you can see that in this particular case, it overlaps. And interestingly, the manufacturer sizing also has an overlap. So you can go 25, you can go 28, and that's a number of things to consider. Difficult one, but there is a new matrix coming from a publication that I personally use, and it helps a bit. And this particular case with 17, so this is like 16, so 17 by and 22, which lands it on 25, and therefore in this case we use a 25 millimeter amulet. So that's the puncture we talked about. Coaxiality to the landing zone is important. The left side is your short axis view. Biplane imaging will give you the long axis view. That's the pulmonary artery here, and that's appendage and mitral valve. Next step would be to put the sheath in and opening the tire or the lobe of the device. The recommendation is that the 2/3 of the lobe should be beneath the left circumflex artery. So that's where they try to do it. In the right side image, you want to make sure that you come coaxial. So you ask the operator to do clock or counterclockwise of the sheath, and this will help to go that direction or this direction. Here is not much you could do, but often because of your puncture, you would be coaxial to the appendage. So you use the biplane imaging or multiplanary reconstruction, and you can see that the lobe is open, and then the disc comes. So the disc needs to sit on the ostium, and the lobe at the landing zone, with the 2/3 of that below the left circumflex artery, as you can see in this video. So there are a few things that you need to do, which is called close. Essentially, what you want in these cases is, as I mentioned, the lobe to be secured um, almost beneath the left circumflex artery, as you can see in the left side image. You want the lobe to be compressed, so you want to measure this, and at least 10% lobe compression is required. The disc must be separated from the lobe, not flatten and attach the lobe. And eventually, you want to see there is no color around the device. And with that, the final checks are done and the device is released. And with that, I'd like to finish and thank you for this very last minute talk.
Thank you so much, Mehdi. That was a fantastic talk and a really thorough explanation of everything. Sorry, I've had to come outside, so it's a bit noisy. One thing I was just going to ask was about how you clear the thrombus. Do you use 3D echo in the same way that you do for the placing the device for clearing the appendage of thrombus, or do you use 2D specifically for that?
So I think, although we've made really good advances in 3D, but the spatial resolution still is a big problem. So for clearance of the thrombus, I personally use 2D, and both even actually without biplane, because it will give you a higher spatial resolution. So sweep from one to the other side as if you are actually doing the sizing, and then biplane imaging. And what we do, if there is a strong doubt, then we use the ultrasound contrast agents to look at whether there is a feeling defect within the left atrial appendage or not. But it's barely and rarely needed, and you almost always can identify the thrombus with 2D imaging. You can do 3D if it's like an absolutely high image quality, and that's something you could do, but I wouldn't recommend that as your standard practice for thrombus. Velocities of the left atrial appendage, as you would know, are important, although if they're in AF, that's already low, but if they are in sinus rhythm, then the 40 is usually the cutoff. So look at the velocities. Color is helpful because if there is a filling defect, the color goes around that, and then you can play with the scale and bring it down to increase your visualization. So those three will give you the answer almost always with regard to the appendage thrombus.